Hello and welcome back. Today we're going to be talking a little bit about how we combine information to help us make better decisions in healthcare or in public health practice. So, as you know, there's a whole lot of information out there that's produced related to how diseases and various different factors affect health in populations. So the process of actually going through all that information and combining together is fairly challenging because as public health agencies or healthcare administrators, we really want to use it to our greatest advantage and to really make decisions that have the greatest benefit for the most people, preferably using the least resources as possible. So in public health practice, how do we think about taking that information and combining it? Well, if you're looking for information about this, there are a range of different places that you can look. One is to the actual scientific literature. So in the scientific literature, what you can find is that there are a range of different things called reviews. These are publications that talk about health-related issues by combining lots of other papers or lots of other evidence to try and help people understand generally what's going on in this field or what's going on for this disease. Okay. So there's a few different types of reviews that I want you to be aware of. The first of which is a narrative review. So a narrative review is a review that where you have an expert of some sort who's really interested in a specific area, and they essentially find different papers that they know and believe are good, and they combine it together, and they essentially write an explanation of their perspective on a health-related issue. Okay. Now, another type of review is called a systematic review. And this review isn't just an expert's opinion on a health-related problem. A systematic review has gone and used a systematic approach to searching the literature. So hopefully they found every single piece of evidence that meets their criteria, which addresses that health problem. So when you look at a systematic review, usually they tend to have less opinion of an expert in it, and they tend to be very more precise about exactly what the evidence is that is out there. The other thing that's nice about these systematic reviews is typically they'll present all of the evidence to you. So you can read through what you see there, and you can actually come up with your own conclusions about what this evidence is saying. So this can be a very strong and effective strategy for trying to combine lots of different information out there. Finally, there's a meta-analysis. So a meta-analysis is taking a systematic review and then going a step further. So there they not only find all the papers that are relevant, but then they extract the information. For example, if one drug is better than another drug, or an exercise intervention is better than a dietary intervention, right? And they take the numbers and then they combine lots of different studies together, the findings from lots of different studies, and they say overall, this drug is better than that drug or not, and here's by how much. Or maybe there's no difference whatsoever, right? So these meta-analyses have the advantage of finding all the papers that are relevant and then taking all this different information where you find many different research papers have different results, and they combine it all together and they say overall across these many different studies, here's what we're finding. So that's how you see all this information combined in the research literature that's out there. There's another approach for combining information, which is called decision analysis. And that's what we're going to talk a lot about in this conversation. But here's where a researcher would try and take as much information as they could about a health-related issue and include, for example, economic considerations, various different social impacts, other factors like that you can quantify, and the health-related impacts, and try and combine it together to help provide guidance to making a decision. So this can actually be a very helpful process. I think it will be interesting for you to see how that's done. Now, ultimately, when we think about using information and combining this information in practice, very often what we'll go to as healthcare practitioners, public health professionals, is to actual recommendations and guidelines. And these guidelines are put together by people who are usually panels of people who are experts in the field. And they take all this evidence from, meta-analyses and systematic reviews and original research papers, sometimes from decision analysis, and their perceptions of how this would work pragmatically in clinical settings or public health settings. And they come up with a recommendation for, do we think that the evidence supports doing this thing? What should you do? What should you avoid doing when you're doing an intervention of various sorts? Very often you even have rankings of how confident they are in these different strategies. So these recommendations and guidelines can actually be quite helpful. But again, they're actually kind of moving very often away from these more scientific approaches. And very often there's a lot of opinion that starts integrating into these recommendations and guidelines. So there is a value to being familiar with that original research evidence that is available through the meta-analyses and systematic reviews and decision analysis. All right. So as I mentioned, when we think about making healthcare decisions and combining healthcare information, it's very helpful to not only think about the disease itself, but also think about how we consider that disease in the context of overall healthcare considerations, public health concerns. So the truth is that we spend a lot of money as a society on healthcare. So here's a chart showing national expenditures on healthcare, and we see that it's increasing over time. Some people, if you ask whether the Affordable Care Act would was actually going to decrease the cost of healthcare, even in the best assumptions, it actually wasn't going to decrease costs. It's just going to decrease the slope of how much costs are increasing for society. So we do have this overall increase in healthcare spendings, and estimates are that by 2023 that we'll be spending about roughly 20% of our GDP on healthcare related issues. So that's a very large expenditure for us as a society. Now, when we think about that and we think about the economics of that, there's a real incentive for us to consider, okay, how can we bring down the costs of healthcare in the United States so that potentially we could use that money for other things? Or maybe we want to spend the same amount of money, but we want to do it more effectively. Part of the reason that we are thinking a lot about this is, as I've mentioned before, in the United States, we're actually not doing terribly well in terms of healthcare provision, in terms of the outcomes of our healthcare system are not that great compared to much cheaper systems in other countries, right, that actually had better health outcomes. So we really need to think about, why are we spending so much, and what can we do to actually ensure that we're getting the best bang for a buck, right? Because that sounds crass to say that, but remember, effectiveness can have a huge impact for people's health, right? And particularly if we're thinking about populations and societies, we know that when we can create better systems, very often that includes creating systems that have better access for more people, right? And we know that people who are disadvantaged tend to be the least likely to have access to healthcare. So how can we decrease that cost, make it more effective, and make that increase that access across the population? So what are some economic concepts that you might think about when you're trying to address these healthcare issues? So one is the idea of resource scarcity. So unfortunately, the truth is that there are limited resources out there. We as a society can make decisions about how much resources we want to devote to different questions. Health is a really important thing. So maybe 20% of our GDP is the amount that we want to devote to healthcare, or maybe it's even more, right? But the truth is that we do have to make decisions, and there will be trade-offs in terms of those resources. And we have unlimited wants. We want to give everything to everybody that they want to have. But the reality is that's probably not something that we can easily do. All right. The other thing that we think about is that the idea that once we spend something on something, on a health-related issue or something else, those resources may not be available for other uses. All right. So that's important to understand that there is there's a term called a zero-sum game. And the zero-sum game essentially means that that's a situation where you have to choose one thing or another. And you don't you spend on one or the other, and the other one doesn't get it, right? So that's often very hard decisions when you're in a situation where you can't benefit everybody. You have to choose between different diseases or different healthcare resources. The other idea that's important to understand when thinking about economics is opportunity cost. Okay, so here what you're really considering is if you choose an option, if you choose that you're going to devote money to lung cancer instead of to heart disease, right? What are you giving up, right? So when we're making this comparison and thinking about these opportunity costs, what is the value of the best alternative to what you're foregoing? So the difference between what you're doing and your best alternative is that difference, that opportunity cost that you're losing in making that decision, all right? So when you're measuring this, you want to think about, for example, what is the opportunity that we're losing by choosing one drug to treat a disease as opposed to another drug, which is your best alternative, as opposed to comparing your drug to doing nothing, right? You want to always compare it to your best alternative option. Okay. All right. So let me ask you a question. We're talking about economics and we're talking about money, and this money has real, and how we use this money has real human consequences. So let me ask you a question about how you think about this. All right. You're not going to like this question, but how much do you think 1 year of life is worth? So take a second and think about that. Even write it down if you like. So this is a hard question, right? Many of you probably find it uncomfortable to think about how much would I actually spend for a year of life. And many of you probably are thinking, well, is it my life or is it somebody else's life, right? Or is it a loved family member or somebody else's life, right? So these are all considerations that come into this. And that makes a lot of people uncomfortable. And often the answer that I get when I ask people about this is, well, life is priceless. It's actually not fair to put any value on a year of life, right? Well, that's an understandable position. And I'm actually not going to try and argue you out of that position. But what I want you to understand is that there is actually costs to that position as well, right? So when you decide that you're not going to actually put any price on life, right, then really it's anything goes in many ways. When we're thinking about how we use our resources, we're not forced to make a decision about how we're going to allocate those resources because we're not choosing between the value of those resources, right? And what the output of them is going to be. So in situations where we haven't said, we'll pay this amount for this year of life and not more, right? Then it becomes, in some ways, those decisions happen through other mechanisms. So we know, for example, when we think about social justice, that typically people who have the most political power, who have the most social resources, are the ones who are going to be able to argue for those resources, right? And those decisions very often are made in the favor of the people who can raise the most interest or power behind their desire to have their health needs met. And very often the people who don't have their needs met are the people who have the least political power. So, for example, here might be injection drug users. If you actually look at the evidence database, evidence out there and the amount of healthcare resources that go to people who have health-related consequences of injection drug use, there isn't a lot there, right? And even though these resources might be very well spent for that population, whereas it might be spent for much less serious concerns for populations that have a lot more political power in systems. So remember that when you choose to not make any decisions, you're essentially leaving it up to other mechanisms for making these policy and health related decisions. Okay. All right. So in economics and health economics, what generally the field has decided is that, yes, we do want to start making some claims about how much a year of life is worth, how much we want to spend for different types of outputs for our health-related resources. So there are a few different ways that this is done in healthcare, and I've already talked a little bit about this in a previous lecture, but we have the health-adjusted life expectancy. That's done at a population level, where they adjust life expectancy based upon the value or the impact of disability on a population during that period of time. Okay. Then we have years of potential life loss. That's a measure of how much life you might lose if a disease occurs. Now, this is an interesting measure because it allows us to see how certain things like car accidents, which we might not think as being one of the biggest issues, is actually a very big issue when you think about years of potential life loss, because the people who get in most car accidents are actually young folks, and therefore they're losing many years off of their life. Okay. So if you add that up across a population level, at a population level, that actually is a really big hitter in terms of health impacts. Or things like depression, which may have less of a mortality than, say, heart disease, but if you add up the impacts across a population, that turns out to be actually really very high in terms of impacts on societies. So it is a way of thinking about this. But if you think only in terms of years of potential life lost, well, that has implications for people who are elderly, for example. Remember, if you're elderly, the number of years that you might lose from dying might be 3, 4, or 5. So that means that conditions that happen in later life, by this measure, may not actually be prioritized. So that would suggest a shift away from resources allocated to the elderly. And there's some people who are very concerned about that in terms of access and justice across age. And there's concerns about ageism there too, right? So even though this is a strategy that's used, there's reasons that people might be concerned about it. Then we have disability-adjusted life years and quality-adjusted life years. Those are the idea of taking a year of life and adjusting it based upon the health impacts that people have based upon different health states. Dalys and QALYs essentially function basically the same way. They're just from two different fields. One's from the social sciences, the other one's from, I think, the health sciences, and the others from economics. The QALYs are from economic fields. Essentially what they're saying there is that we're going to take each health state that somebody has and we're going to rank it on a utility scale. And what is a utility scale? Well, it's essentially saying that if you have two extremes, death being one, death being 0, right? That's one extreme, and 1 being perfect health. For every possible health condition, we're going to rank them along that scale. And that's going to allow us to adjust the value of a year of life based upon the quality of life during that year. Okay. So, for example, here, if you took the state of having congestive heart failure and the real pain and difficulty of having that, you might say, for example, the quality of life having that disease might be, let's just say, 0.5. So then you'd say that year of life is worth half as much as a year at perfect health. Okay. So why do they do that? Well, they do it because what they're hoping to do in measuring this difference is to figure out how they're going to allocate resources. So a disease which has a bigger impact, you might focus more resources on ensuring preventing that disease, for example, or helping people with that disease to reach a better health related state that's less impactful. So that's the utility scale. Now, I'm about to tell you why there's concerns with this approach to doing things. But what I'll say before I get into that is it's important to note here that regardless of whether you like this strategy or not, it's really important to understand how this is done, because this is how healthcare decisions are often made at a societal level. So even if you don't like it, and even if you disagree with everything I say here, I'm actually entirely okay with that. There are disability rights activists who are really troubled with this whole strategy for ranking different health-related states. But it's important to know how this works to effectively engage in that conversation, regardless of which side you are on for this. All right. So what are some ethical concerns about this strategy for thinking about health? Well, one is that there's some assumptions that are violated by doing these strategies. So, for example, we very often think we have a duty to rescue, right? So this comes into play when we think about acute situations that are very serious. So we feel like we might have more obligation, for example, to save someone who is almost dying of cancer, for example, than to do, say, a population prevention effort that affects lots of people, but maybe is less of a severe condition, right? So that's saving a child in the well, which costs millions of dollars, for example, versus doing population level funding for fluoride treatment for all children in the state, right? One's fairly cheap. It affects millions of children. The other one might save one person, right? But we as a society very often make the choice to save that one person because they're in a serious situation, right? So when you think about these economic systems, it disregards that. It actually adds up, the benefits of doing one strategy and the benefits of doing another strategy, and it comes to this decision based upon that about what we're going to invest our money in to have the best overall outcome, right? So then the question would be, okay, if we're going to make these decisions about what the value of life is in different health-related states, well, who's going to actually make that decision about how much that is worth, right? So remember, when you're making claims about the value or the ranking of different diseases, you're actually making claims about people, real people, right? So there are people there'll be people in the class who are listening to this lecture who have disabilities of various sorts, and you have to think about yourself. Well, how much is my life worth? Do I like the fact that my life is worth less than other people perhaps around me according to this framework, right? But a question here would be, well, how would we even measure this, even if we were trying to do it? Well, that's kind of a challenge, right? Because there's different folks who you could ask to try and measure this. You could do surveys, for example, asking how people think about this. So one strategy is to do surveys of patients who have a condition, okay? Well, what you find, some people would argue that this is totally okay, but there is cognitive coping mechanisms, so that once people have a condition, that they cope, and one of the mechanisms is perhaps to have a more cheery attitude towards that condition than someone might think otherwise, right? That's a criticism that's been leveled at doing it this way, right? That people might have an overly cheery attitude towards this who have a condition. Another question is, another strategy might be we just do a survey of the overall population to see how people think about a disease, and then we use that population understanding of a condition to rank that on that utility scale. Well, the problem is that the population tends to not really understand these health-related traits very well. For example, if you ask people from the general population what the experience of blindness is like, very often they rank it as being very low. So they can rank it on, 0.3 to 0.5 on the overall utility scale. Whereas if you talk to people who are blind, very often they become blind. They go through a period of adjustment. But they go back to essentially living their lives and feeling quite healthy, right? So we see a huge disconnect, and there tends to be a real overemphasis on these sort of more acute or cognitively prominent sort of things like losing a limb or blindness or deafness among the general population, that when you look at the people who have it, they tend to really adapt really well. But the general population also tends to really underemphasize how serious and painful some chronic conditions can be. And these are conditions, say, like chronic severe arthritis. If you look at chronic severe arthritis, people have these really painful experiences over long periods of time. If you actually look at patients' own evaluations of their experience of that disease, they actually rank their quality of life really quite low on that utility scale. So the population isn't really great at assessing these values. And then another strategy is to ask physicians or clinicians of various sorts to ask how they think about the quality of life in a different condition. Well, there's a few reasons why this might be a problem too. Well, clinicians, if you think about it, clinicians see patients when they're at their worst. So clinicians very often have a much more negative view towards a disease than the people who have that disease, because they have they typically see people who are suffering the most of it. Remember when people after people leave the clinic, they go back home, and very often, if they have care, they might actually be perfectly happy, but the clinicians don't see that, right? So you can see that I have a perspective on this. I really think that patients often are the best people to assess this. But this is an active conversation about how do we evaluate these health-related conditions. The other thing to ask is, if you have certain health conditions, people can actually do self-report. They may not have the ability, for example, cognitive capacity to do a survey or something like that, or perhaps having dementia, for example. And then how do you measure the quality of life? Do you use proxies? Do people make decisions for individuals who have different disabilities in that context? And because of all these concerns, there's concerns that this process could potentially devalue the life and experiences of, for example, elderly people when you're thinking about the life year strategy, or people with disabilities, right? So this is a really important critique to understand. And I think that it's helpful for seeing the complexity of making decisions around economics and health and quality of life, okay? And the other thing I'll just mention here, because I think it's helpful and interesting, is the idea that when we do these decision analyses and cost-effective analyses, we'll come up with some number which says, we'll save the most money by doing this. And it sounds like these numbers very often sound very simple and objective. But it's important to remember that numbers often hide behind them a lot of social values. And this is a great example of that, to illustrate how numbers aren't objective and neutral. They often have social values behind them. All right. So let's go forward. So how do we think about this? Where do we, if we are going to go forward with saying that there is that quality of life makes a difference in terms of health? And while there have been criticisms of that, as I just mentioned, that is the overall intuition that most people in health economics and health policy decision-making have. That's the decision they've made, that we do think that quality of life does make a difference for people's well-being, and that we are going to make healthcare decisions based upon trying to maximize the health impact of the use of our money and resources. If we were to do that, where would we draw the line? And this is answering the question that I gave you earlier. How much is a year of life worth? Well, there is actually a rule of thumb in the United States. Generally speaking, if it's less than $20,000 per life year, that intervention is generally seen as being really good. If it goes 20 to 40,000, this is pretty common. You see this for many commonly used health-related interventions. When you start getting into the 80,000 to 100,000 per life year range, that's when it starts pushing into the questionable category. Insurance companies sometimes will cover that, sometimes they won't. So that's where you start seeing a bit of a transition. And then once you get over 100,000 per life year, then it becomes seen as being generally questionable. Now, these are a rule of thumb in the United States because we have private healthcare insurance to a large extent. We have the ways that decisions are made for Medicare and Medicaid, but also private companies have their own processes for making these decisions, but they tend to vary substantially across our population. So these are really rules of thumb in the United States. In Great Britain, for example, they do have a threshold, and I believe it's £50,000 per life year. So it's going to depend on where you are, how they put this threshold down in terms of what they'll fund in terms of healthcare and what they won't. So we have a few different examples. There's a range of different things that are out there in terms of the amount of cost per life year. So we can have everything from IG treatment for chronic leukemia to help protect people's immune system, down to NICU, neonatal intensive care, right? So if you look across those different treatments, there's actually quite a range. And there's some things, for example, mammography for 40 to 49, which actually kind of is on that upper level, but we do fund that. So we will see a range there. Now, one thing I'll point out here that, again, is kind of interesting about the life year approach is NICUs are actually, the top one, are actually really very expensive. That type of care is actually quite costly. But remember, if you do an effective treatment for a baby, they could potentially have a whole long life of, 80 or so years, right? So you're saving a lot more life years, even though you're spending a lot early on. So how do we think about costs when we think about these economic analysis? So there's a direct cost of medical intervention, some sort of treatment, the drug or the technology or the surgery or the public health intervention where you're promoting exercise or quitting smoking or whatever it happens to be. Then you also want to look at things like that extend beyond that direct cost, right? Because costs, you got to think about them in a more complex way than just the cost of that pill, right? So what about the fact that, for example, some treatments actually have adverse consequences? You have adverse symptoms, so you also have to treat those. That is also something that you need to think about that. You also want to think about what are the savings. So, for example, when you treat infectious diseases, you actually are preventing other people from getting it in the future. So that's a saving from doing that. And then there's also the costs of treating future diseases. So people who are saved from dying actually can go on and develop other diseases later on. So those could also be costs that you could consider, right, in this evaluation. So again, it's starting to get complicated. But it can get actually even more complicated to think about different costs in healthcare. So one is the direct non-medical costs. So remember, it costs money to travel to a clinic, for example, or it costs money. People lose money by sitting in the waiting room, for example, or waiting, having a long period of time that they're waiting for a treatment. As you may very well know, taking care of people, taking care of your family members, these caregiver costs are actually substantial, right? So people who spend their time and their energy taking care of their family members, well, that means that they can't be working in paid positions, right? And that's something that we as a society really undervalue typically. So in actually measuring the economic value of things, we really would want to consider caregiver costs in this. You could also think about indirect costs. So things like, what is the cost of how much time people lose getting the flu from their job, how much cost that is economically to production when people are absent from their job. And then you could also start evaluating other types of costs. For example, what is the psychological stress of suffering or pain that someone has in a different condition? And that could be because they're taking the treatment, or sometimes it could be when they don't have access to that treatment. So you could try and measure that and integrate it in. The other thing I'll just mention here in terms of costs that I think is helpful is that there's an idea of discounting. And this is kind of an interesting concept, which is the idea that future costs or impacts are seen as being less valuable than benefits that we get right now. All right. So this is an interesting psychological phenomenon, because if you have the same benefit now versus 3 years from now, in theory, you'd think, well, it's actually the same thing. But if you actually look at a population and you study people's attitudes towards it, people value the benefit that they can get now more than the benefit that they will get later on. So what they do in these economic analyses is they apply something which is called discounting. So essentially they discount the value of an outcome, a benefit, by 3% every year in the future. Okay, so this is a commonly used strategy in economic analyses. All right. So what are the advantages to doing decision analysis? So I've talked a little bit about some of the ethical concerns about it, but there's some real values to taking a systematic approach to thinking about health-related economics and decisions in terms of the benefits and risks of taking on a new strategy. So one is that we as people have a lot of different unconscious biases. And what decision analysis can do is it can help us to minimize those biases in addressing these decisions. So I mentioned before the duty to save bias in this. This sort of takes a more balanced, neutral approach to that, whether you like that or not. So what it tries to do is it tries to include all relevant options. Okay, so it's not just talking about the drug, but it's also talking about what the best alternative drugs are, right? So it's thinking about what are all our options in this situation, right? Sometimes people will set up, when they're making decisions, they'll set up false dichotomies. They'll compare a drug to no drug, and that's not the right comparison. It's really the drug to the best alternative that we care about, all right? We also want to, when we do this analysis, we want to pull in as much information as possible about a health-related condition. So that gives us lots of different evidence to think about, both from randomized controlled trials to population studies. We can even sometimes integrate expert opinion if we don't have better sources, right? We can also think about timelines. So strategically, how does this occur over a period of time? So you can integrate that into these processes to really think about this concretely in terms of what benefits would occur and when they would occur. And by doing this, we actually, as decision makers, we can minimize those biases and hopefully actually make better decisions that will have greater overall population benefits. Right. So that's the idea behind using these decision analysis approaches. So what is cost effectiveness? Cost effectiveness is really talking, we talk about it all the time, right? But what it's really trying to say is how much benefit are we getting for an increase or decrease in money that we're putting into something. So it's incremental. So we look at the change in cost divided by the change in effectiveness of an intervention, okay, or effectiveness of treating a particular health condition, okay. And again, here we're looking at compared effectiveness, comparing the treatment that or the new intervention that we want to do compared to the best or standard alternative that we're interested in. So let's look at this a little bit differently. This is called the cost effectiveness plane. And I think that this is really helpful for thinking about how we consider money and use of money in public health and at a policy level. Okay. So this is, if you look at the X and Y axis, you go from the possibility of a new treatment being less effective, right, to a new treatment being more effective on the other side of the chart. Then you also have the idea of a new treatment being more costly versus a new treatment being less costly. And again, you're comparing there to the best alternative or standard treatment. Okay. Now, the line that goes up through the center there is sort of a tipping point for that cost effectiveness plane. So there are 4 conditions on which it's very clear that there's a right answer, or it's really quite clear that there's a right answer in making these cost-effective decisions. One is that the existing treatment is both, if the new treatment is both more costly and less effective, then the existing treatment is going to be the one that we'll want. We're not going to adopt a new technology if it costs more and it doesn't work as well, right? The other possibility is that the new treatment is less costly and it works better. Then it's kind of a no-brainer again. Well, why don't we just do that new treatment? Now, there's 2 other quadrants here, and that's situations where the new treatment is less costly, but also less effective, right? So this is a situation where maybe we want to spend less and save money, but we also recognize that it's not going to be quite as effective, okay? So that can be a trade-off that is sometimes made in public health. Sometimes they'll decide to go and save money, but recognize that it's just not going to be quite as good as our best treatment option, okay? Another possibility is that the treatment is more effective, but it's also more costly, right? So here you might say, it costs more, but I think, we're going to do this. We think it's worth that extra money, or we think that it isn't, right? So in those quadrants, really sometimes decisions go one way or the other depending on the considerations that are being dealt with in that healthcare system. So another thing I want to clarify when it comes to cost effectiveness is that there's actually a difference between cost effectiveness and saving money. Okay. So Benjamin Franklin said, an ounce of prevention is worth a pound of cure, right? But it's not necessarily the case that it actually costs less. So when you look at the U.S. Preventive Services Task Force, which is the U.S. Body that really thinks about prevention and public health and recommends different healthcare and public health strategies based upon the evidence. Well, there's an evaluation that looked at 25 of the recommendations that the U.S. Preventive Services Task Force put together, and they found that only 5 of them actually saved money. Most of those, the remaining 20, actually cost more, right? So for these other recommendations that this body is saying are really valuable, they're essentially saying, look, it costs more, but it's worth it, right? We as a society will benefit from overall improved health enough that's worth us actually putting that additional money into this, right? So sometimes just because we're spending more money doesn't necessarily mean it isn't worth it. All right, so let's talk a little bit about decision trees. So decision trees are essentially a strategy for going through a health-related decision and parsing it out based upon the criteria that I've discussed earlier on in this lecture. So the first thing you need to understand in looking at these decision trees is the idea of a choice node versus a chance node. All right. So the choice node is represented by a square, and that's where you're choosing between an intervention, 1 or 2 interventions. Let's say that intervention 1 is pill A and intervention 2 is pill B. Okay, so these are 2 different medications. You're choosing between them, all right? So you have to choose one or the other in this situation, okay? Then there's a chance node, and that's represented by the circle. And for every choice that you make, if you choose pill A or pill B, you could have any of a range of different outcomes. It could help people get better, or it could not help people get better, right? So you have different possibilities there, all right? So that's a chance node, right? So again, that's trying to measure the probability of these different outcomes, right? So here in this example, if you have intervention 1, say drug 1, this might be a case where for people who get this intervention, you have about an 80% probability of curing somebody, but someone's chance of dying is about 20%, okay? So there's that range of possibility there. For intervention 2 or pill B, there's a 70% chance that you be cured, a 20% chance that you become blind, and a 10% chance that you die. Okay, so that's how you see the choice and chance nodes sort of interacting to show you how these different options are different. Okay, so then in theory, you could then take those numbers and multiply it out by our measures of utility. Remember that utility scale that we measure the health impact and the quality of life for different diseases. So here, the assumption in this slide is saying that the utility of life is 1, the utility of death is 0, and then the utility of being blind is 0.5. Okay, so if you measure out the overall effectiveness and utility of taking on these two different options, what it turns out is by these numbers, they actually turn out to be exactly the same. So the overall total number for them is both 0.8, right? So in this case, you could go either way because there doesn't seem to be any difference. So let's say, in this case, maybe we think that the utility of blindness is something quite different. So if you actually ask people who are patients about the utility and their self-evaluation of the state of blindness, it tends to be much higher, right? And I think it's actually higher than 0.8. But what we see here is that then the overall equation changes when we change that utility value. So now the pill B is actually 0.86, whereas pill A is 0.80. So what that's suggesting here is when we calculate this out, that pill B is a better option in this situation. Whereas if you say that if you bring that utility value for blindness down, well, then it goes to 0.04, and then you have a overall effect for pill B of being 0.74, right? Which is then lower than the option of pill A. So you see how these decision analysis processes allow us to have sort of a mathematical and scientific way of evaluating different options and the implications of options. You'll also see why these utility values are actually really controversial, because they can make a real impact on decisions about what we fund and what we don't fund based upon those evaluations. So I wanted to show you how complex this gets. Again, when you think about cost effectiveness and you're thinking about this in a broad way in terms of broad healthcare impacts, well, it actually gets really complicated because you're bringing in a whole lot of different types of information. So here's an actual real cost-effective analysis. And you see that when you have those choice and chance notes, it starts breaking out into these very complex calculations. Now, if you actually look at all the different types of information that's included in that decision analysis, well, you have everything from how likely people are to adhere to a treatment if they do get a treatment. There's factors like what are the ages that people are likely to get a disease. We look at how likely people are to die related to disease, how much it would cost to treat that disease, how much it costs to do the treatment, the intervention. We can look at how many people are likely to actually do this treatment or if it's offered to them. So you can look at many different types of information, and for each of these things, you can calculate the probabilities of these different factors and the cost of these different factors. And that allows us to actually make a calculation based upon this. Now, again, the assumptions that are used for each of these measures are based upon hopefully the best evidence available, but they will always be somewhat controversial, and that's okay. That's something that should be a conversation when we make these complex and serious decisions for healthcare in a population. But at the same time, remember, if you don't consider all these options, you don't have a way of really thinking about this in a systematic way, right? And that's when sometimes decisions are made based upon, say, political power as opposed to a more systematic decision-making process. So something to consider there. So when you actually do this, what you find in this case is that it turns out that up to, this is in euros, for example, up to about 70 or 80,000 euros, it actually seems to make the most sense to do nothing in this case. Okay, 70, 80,000 euros, especially at the time this was done, would be something well over $100,000 per year, per life year in terms of benefit. So this cost-effective analysis says, even though we were really excited about this new genetic technology, this new test that we thought was going to help prevent disease and help people out, what the data is actually suggesting is, well, no, your optimism might actually not be that great, that's promising. It actually turns out that maybe doing nothing is the right thing in this situation. And really, you have to be willing to spend actually a fair amount of money per life year in order to argue that we should actually fund this new public health strategy. So that's why these decision analysis tools can be helpful. So they could say, maybe we don't want to spend money on this new public health intervention, but maybe we want to focus on something else that we think will give us greater overall public health benefits. So that's cost-effective analysis for you. That's some of the strategies that we use at a population level to make these policy decisions around funding of different healthcare. All right, so that's it overall. Again, there's ideas here around how do we combine information and health. So sometimes that's done through the literature where you create various different reviews that inform us. Sometimes we use guidelines. Sometimes we use what I discussed here, which is decision analysis, which is a sort of way of taking lots of different information that are relevant to healthcare systems and trying to combine it together to come up with a recommendation on what strategies to use and what to fund through a healthcare system to have the greatest overall effectiveness. So interesting stuff, worth learning more about. I think it's a really great field that can potentially, when we talk about the overall cost of healthcare here in the United States, if we did more of this sort of systematic analysis, it might provide us with lots of opportunities for improving our healthcare system. So thank you very much for listening, and take care, everyone.